and thanks for the opportunity. Thanks for the All India Ophthalmic Society. And my talk is on world's largest series on pellet ocular trauma. And thanks to Dr. Fidro, who was a great friend of India. And I was fortunate, even though I was very young, I became his friend in 1983. And I wanted to use the same 93rd Dr. S Fidro birthday, and our hospital and Lions Club of Rourkela are celebrating International Ophthalmology Day and doing a public webinar on public awareness on eye care. Thanks to my good friend Boris, the president of the Russian Ophthalmic Society. So reaching out to the helpless pellet victims in Kashmir. So there was a curfew in Kashmir in July 2016, 4 years back. The entire streets were like this deserted, and suddenly there were mob throwing stones, and that's how the pellet ocular trauma happened. You can see the pellet ocular trauma, the bodily injuries which happened more than 10,000 people, and about 11,111 had pellet ocular trauma. And out of this, we have analyzed 777 patients with the complete data on age and gender. The mean age was 22 to 22 years, and there was a predominance of male gender. 97.7% were males, and the most common age group was between 20 and 29. 397, 51.5%. 1%, followed by age group 10 to 19, over 284 patients with 36.6%. And this is me operating in Kashmir. The Sri Maharaja Hari Singh Hospital had well-equipped operation theatre, the Zeiss microscope, the wide-angle observation system, and also the Alcon constellation. There's no financial interest. There were dedicated assistants who assisted. There were 25 ophthalmologists in the department. Thanks to Dr. Tariq Qureshi, who was the head of the ophthalmology department, and all the ophthalmologists who worked there. We should appreciate them. You can see in this picture, patient who had undergone a corneal wound repair, came with a total cataract, and we decided in the International Society of Ocular Trauma, and I'm also the president of Asia Pacific Ophthalmic Trauma Society, where we decided after any injury, within 6 days, we should do the secondary repair. You can see the corneal wound repair with a total cataract, ultrasound done, and the CT scan showed that the pellet had gone through and through the cornea, through the lens, vitreous, retina, and back into the orbit. So this is how the patient came in a week's time, and you can see the corneal suture here. The cataract surgery was done by my colleague, Dr. Kavita Rao, who is the director of cataract and cornea service. And usually I ask the anterocerebral surgeon to do the cataract, and he is doing a paper aspiration, and then and then did a intraocular lens implant. And after that, I take over and do the 23 gauge 3-port vitrectomy. And in this case, we after removing the vitreous hemorrhage, you'll be seeing there was a vitreous hemorrhage and submacular hemorrhage. Since it was within 8 days, within a week after clearing the vitreous hemorrhage, I made a fine retinotomy and then did a drainage of the submacular hemorrhage at the edge of the arcade, so that we did not damage near the macula. And then also used endolaser around that micro retinotomy, and then did endolaser, and then we used silicone oil as a dampener, and completing the anterior posterior traction, and also the peripheral base excision. And then at present, I'm doing the endolaser around the retinotomy, and you see the optic disc and the macular region are clear, no blood. Away from the macula, there was some subretinal hemorrhage. We left it as it is, and at present, we are doing an air silicone oil exchange. And then the under oil also, we done the laser around the retinotomy side. And then you can see the ports are removed. And this is the post-operative picture 6 weeks later. And because of the corneal destruction, the vision is about counting finger 1 meter. Pressure was all right. And we removed the cornea. Later, maybe some refractive surgery to be done for correcting the corneal astigmatism. This is another eye. You can see most of them are young people. This is a phakic eye. So we have done a 23 gauge 3-port approach again. And when the lens was cleared, we didn't do any lensectomy. and we completed the vitreous removal of the vitreous hemorrhage, removing the anterior posterior traction, and then I make a connective incision in the 11 to 1 o'clock, and then sclerotomy also extend 11 to 1 o'clock about 5 to 6 millimeters, and then use forceps with a four-pronged forceps designed by myself, Mahesh Shanmugam, and Dr. Manish Pape from Nasik, where we grasp uh, the pellet, which is about 4 into 5 millimeter of pyramidal, like the polygonal shape, with the made of lead, and we make sure that the pellet is grasped within the vitreous hemorrhage, and then the vitrectomy is completed. The idea is the pellet should not fall rolling on the retina, because while removing again, you can have hydrogenic retinal break. So this is a small trick which I designed. You can see the impact site near the posterior pole, and then the pellet has fallen in the interior part of the vitreous hemorrhage. So before removing the total hemorrhage, I'm using the four-pronged forceps, grasping the pellet which is within the vitreous hemorrhage, which is made an incision through the conjunctiva and the sclera, and then removing it, and you can see that the vitreous hemorrhage was squeezed off, and then the sclerotomy will be closed, and then the conjunctiva is closed, and this is the pellet which is being removed. And it's only within the eye we remove it, and we close the sclera, and then also the conjunctiva, and use the three ports, continue it, and complete the peripheral vitreous base excision, and also do the laser around the impact site. And then this is another eye where you can see in a phakic eye, where you will see the corneal sutures now. So you can see the corneal suture. We have already a lensectomy done because there was a traumatic cataract, which is hemorrhage. So now we are using the four-pronged forceps, as I told, designed by myself, Dr. Manish Pape and Mahesh Shanmugam, published as in Indian Journal of Ophthalmology. So you can see the pellet being removed through the sclerotomy. The sclerotomy will be closed with a micro suture, and then after completing that water suturing, we complete the vitrectomy, do the vitreous base excision, and identify the site of impact. And we expect there is a retinal tear, so we do an endolaser around it. It's treated as a coloboma chloride. And fortunately, this patient had a exit wound and the impact wound close to the optic disc, not exactly at the optic disc. Many patients had injury to the optic nerve and the macula. So those patients, in spite of excellent anatomical success, the vision did not improve. But if the macula was spared, the central cornea was good, and even if the patient was aphakic, we can do a secondary IOL later, and then the patient visual rehabilitation can be done. This patient had a good visual recovery because the macula was spared. And recently in the this is another eye where again we are seeing the pellet being removed. And this is the last video where this patient, the pellet was, the initial wound repair was done, and then the patient went back to the village in a few kilometers from Srinagar. And then when they came a month later when I went, so there was a suprachoroidal hemorrhage, there was a vitreous hemorrhage, hyphema, and I actually used the AC maintainer to do the infusion of the eye, and then use the myrigotomy knife to separate the clot from the posterior surface of the cornea. And I used actually the viscoelastic, and then place the trocar posteriorly to drain the suprachoroidal hemorrhage, which was, you can see the fluidic choroidal suprachoroidal hemorrhage being drained. Again, one more port we are putting posteriorly. The idea is it is not done through and through, so that the part of the port is left within the suprachoroidal space, and by increasing the intraocular pressure, the suprachoroidal fluid is drained through the trocar, and we are squeezing the eye to drain off the suprachoroidal hemorrhage as much as possible, and then we proceed with the three-port vitrectomy, and using the AC maintainer as the infusion, and again going through the limbus, clearing the vitreous hemorrhage from the pars plana region, so that when we make the trocar cannula through the pars plana, we make sure that the which is the port is the instrument is exactly in the vitreous cavity, so that you can see a lot of vitreous clot, a blood clot over the base, and then you have to make sure that the entire thing is penetrated well, so that you don't produce a suprachoroidal detachment while doing the vitrectomy. And you make sure that the port is very well toileted by doing a vitrectomy. And then you can see subretinal hemorrhage, suprachoroidal hemorrhage, and this looks like a totally gone case, but I don't give up, and I actually complete the vitrectomy and then open up the funnel and then use perfluorocarbon liquid to squeeze out the subretinal hemorrhage. And I actually use either the existing bag or make a peripheral retinal retinotomy and use the perfluorocarbon liquid to squeeze out the subretinal hemorrhage. And you already saw the ports are kept open in the suprachoroidal space, so that if there is a residual suprachoroidal hemorrhage, that is being drained out when you are increasing the intraocular pressure. It need a patience, you need persistence, you need a perfection in doing the surgery. And this is what the New York Times article covered in 2016, and which was quoted by the president of the American Academy during the recent rubber bullet injuries which have happened in America following the George Floyd killing. And you can see the peripheral subretinal hemorrhage drainage, and you can see the retina getting attached when you're using the perfluorocarbon liquid, and you have to do a thorough with a basic excision and remove all the and flatten the retina, and then also after clearing the subretinal hemorrhage, you can see still some subretinal hemorrhage is coming through the peripheral retinotomy, and then which is coming over the perfluorocarbon liquid anteriorly. You also drain it and then you finally do a PFCL oil exchange. And so you can see at the almost at the nearing the end of surgery, where after clearing the all the retinal folds under the perfluorocarbon liquid, endolaser is being done, and the eye looked terrible, but at least you had a attached retina at the conclusion of 3 hour surgery, and now we are doing the PFCL silicone oil exchange. And I think it's a back-breaking surgery. That's the reason which retinal surgeon has to be not only courageous, you have to have a strong back so that you operate. And here, when I was doing, you can see the optic disc and the macula attached. And then I was operating from morning 7 till night 11 in Srinagar. Thanks to the entire team in Srinagar who are very cooperative. And at the conclusion, I keep the air in the anterior chamber. And then this is the team, and I have taken 2 of my ex-fellows, who is now one in Africa and one in Delhi, Dr. Kenshuk, and that's the team in Kashmir. You can see Dr. Tariq Qureshi, who is the head of the department, and their social workers, and the Borderless World Foundation, who have donated the ambulance called the Kashmir Lifeline, as well as they took me from Mumbai to Srinagar for doing the surgeries for 5 months. I went 5 months, and thanks to the government of Kashmir, who gave me an outstanding citizen award. Thank you very much.